We're here again to talk to you about another important health topic. We're going to talk to you about a topic that affects 40% of Americans. Can you believe it? Almost half of America is affected by this disease. We're going to talk today about obesity because obesity is a growing problem in our country. Obesity leads to a lot of medical problems. The diabetes, the high blood pressure, the breathing problems, the increased risk of cancer with obesity is obviously what we're seeing because of this chronic condition. We know that obesity also affects children and adolescents. It has really grown in that area. We're going to touch upon obesity in the adolescent population as well. So to talk about obesity, we have to bring an obesity expert. We have to bring somebody who obviously understands obesity, weight management, and how to be healthy. And so today my guest is Dr. Lisa DeRosimo. I want to welcome Dr. DeRosimo here to be with us.
Thank you for having me today. It's a pleasure and an honor.
All righty. Well, we're going to talk about obesity and weight management. So, Lisa, first, just tell us a little bit about yourself and how could you be an obesity expert?
Well, it's an honor to do this. When I was young, I followed my mom around to many clinics. She was trying to lose weight. When I was little, we went in and out, tried numerous diets and different quack things and fads and everything, and she always had a problem. And when I got older, I lost about 30 pounds as a teenager. And then I got more and more interested in nutrition and weight management when I was in college, and I've done it for a career ever since, and it's very fulfilling. I love it. I love to see the patients succeed, and I love the ability to talk with them for long periods of time and spend time getting to know them and change their life.
Well, yeah. I mean, let's full disclaimer, Dr. DeRosimo takes care of my family as well. So she's obviously, I trust her not only to give us good information today, but to care for my patients. So what does an obesity medicine doctor really do?
It's a good question. So lots of people don't even realize they have a problem with weight. And then there's other people that just want to lose weight to look better or feel better. But it is a multifaceted chronic illness, obesity, and it's plaguing, as you said, 40% of Americans. And then overweight is leading into this, prediabetes, high blood pressure, cardiac problems and whatnot. And it's when the fat cells go bad, there's dysmetabolism, and your body actually starts to have different signals, and it's harder to lose weight when you have this. So obesity is a chronic, you can even say it's a pandemic, that it is a chronic problem around the world now, and it's something that needs to be done so that people can live healthier lives and live to their full potential.
Yeah, and one of the things, not only have we noticed it in adults, but now we notice it in children as well. We're going to talk about the children in regard to the new recommendations by the American Academy of Pediatrics. So how does somebody know they're obese? Of course, a 400-pound patient will know that he or she is obese, right? But the everyday patient may say no, and as I know, men are less likely to believe that they're obese, right? Because there's less stigmata with obesity in men. So how do we measure that obesity? There's a blood test for that?
No, there's no blood test, but there is a measurement. It's called the body mass index, and that's the universal standard. You can get on a scale, you can look at your body fat, but looking at your weight in relation to your height is the best way to make an objective measurement. And there are standards across the country, the World Health Organization, that says that if your BMI is over 27, then you're overweight, and if it's over 30, you're obese, and then there's levels of obesity after that. So the BMI is the standard that's most accepted.
Yeah, and for clarity for everyone, the BMI is the body mass index calculator, and people always ask me of that as well. And so just go online, just put BMI calculator and put in your height and your weight, and it's going to give you a number. And so obviously, above 30, then we're really concerned. Is that right? Level?
Exactly, right. Yes.
Okay, and so, as people who are listening, they're probably going to check for themselves, but at what age are we starting to be concerned about obesity?
It's a very good question. Nobody's born obese, so I was thinking that on the ride over here today. But after about 2 years of age is really when there's a notice that there's trending of more problems. The comorbidities are starting to go up at 2 years of age. So the new statement that came out for children starts at 2 years of age, and anyone after that is at risk, because that's really when there's going to be an effect on your health.
So you mean if I have a 6-year-old, a 10-year-old, a 12-year-old, I should really start doing things? They're not going to outgrow that obesity, just by growing up?
Probably not. So this is really, as I said, a chronic problem that is starting younger and younger. So if something's not done drastically for people to be eating better and exercising more, and the whole family making a point of making an effort to be healthy, then it's not going to go away on its own.
Okay. So now I'm at home. I figure out that I'm obese. My BMI is 35, 33. Let's not get into the extremes of BMI like 40 or 45, but 35, 33. I seek evaluation by a weight management specialist, an obesity medicine specialist like you. What is the treatment like?
So that's a good question. There are 5 different areas or pillars, as we call them, for weight management. There's eating differently, there's exercise, there's lifestyle change, there's medication, there's surgery, which you know all about. So there's 5 different ways you can go, and it's gradual. You start with the basics. Everyone should be eating better and exercising more. There's no way of doing anything to make lasting change without changing your diet and exercise. And then you have the lifestyle change, the medications, and we have some good things now, and surgery is one of the last efforts after you've tried the other things.
Okay, so let's keep surgery aside. We're not going to talk about surgery today. And so let's start about lifestyle changes. Let's just, before we get into the complicated diet, because, you know, we're going to obviously ask what is the best diet that exists, but lifestyle change, what does that mean by, I understand exercise, I understand eating correctly or dieting, and lifestyle change, what does that mean?
Lifestyle is really making an effort, having a plan, doing things that are a little different, like making a shopping list, going to the grocery store and having a plan while you're there, going around the perimeter and picking things that aren't in the middle where the fast foods and the convenience and the snacks and everything are. It's making an effort to have exercise in your life, making it on your calendar, something that doesn't add in at the end of the day. It also means the whole family getting involved, that you sit down as a family to have dinner together at least a couple times per week, that you have foods available, that you have a plan when you're traveling, that you have snacks available, that you have water with you. So it's simple little lifestyle changes that can make a little difference that adds up to make a big difference overall.
Yeah, but these are not little differences. These are a lot of differences. These are a lot, those are really key, you know, changes that, you know, everything from having a plan. I think I tell my patients the same way. You have to plan your meals and you have to make, what are you going to eat the next day and what are you going to do? You can't just leave your house without that type of plan. And I think one of the other important things you said is making time for exercise. Yes. And I tell patients, you know, they're all worried about their kids and their family and their spouses. You got to take care of yourself first before you can help others. So I think that's very, very important. Okay, so diet. What is the best diet?
The best diet is the one that you'll stick to. That really is the truth. There are thousands of different diets you can go on, low carb, low fat, low calorie, prepackaged meals. There's so many things you can do, but it's the one that you will stick with long term is the one that's going to make the best difference.
So are there any bad diets? Of course, a bad diet is something you can't stick to. I guess it will be the opposite,
That's
right?
That's true.
But are there bad diets? I mean, I lived through the era of the Atkins, right?
Right.
That was got a lot of popularity, very good, and is Atkins still a good diet?
It's renamed as the keto diet. So it's still here. Not everybody can stick with it. And now, if you skip breakfast, it's called fasting, intermittent fasting. So things that were bad in the past have a new name and they're repackaged so that they're given again now.
So back to the bad diet. What's a bad diet?
If it's imbalanced, if you're really cutting out a lot of food groups and you're avoiding something for a long period of time, that's not good. And the best diet overall really is as far to vegetarian as you can do. But that's a hard diet to live by. Fruits and vegetables are the healthiest thing for us in their natural form. You can't bread them and fry them, but if you're eating fresh vegetables that are cooked in a healthy way, that's the most impact of anything they've seen for health and prevention is a vegetarian diet. But I'm not a vegetarian because it's difficult to give up meat and chicken and fish and the things we love.
Wow, okay. So a well-balanced diet and something you can stick to.
Correct.
All right. And so that's why a lot of times people say you shouldn't call it a diet, right?
That's right.
It should just be a eating lifestyle or an eating habit.
Correct.
Right? And so when people are dieting and people are seeing you and they're changing their lifestyle and they're exercising, what type of weight loss should they be seeing?
It's a good question. People always want to lose it overnight. People think that they're going to lose 10 and 20 pounds a week, but it's really 1 to 3 pounds per week is what your body can do. It can't lose more than that metabolically. It has lots of different safety mechanisms to keep you from starving to death. So 1 to 3 pounds per week is what's realistic.
Okay. And then I'm dieting and I'm eating correctly and I'm seeing Dr. DeRosimo on the periodic. And of course, we get together for football, playoff, Super Bowl, and there's pizza and there's chicken wings, and I ate the wrong stuff. I'm going to get fat now?
No, you're not going to get fat.
You can't get fat on one meal?
You cannot. Your body compensates. It knows right away that that was too much, and it automatically burns a little more calories. There's studies to show that. If you overeat once or twice, you're fine.
You know, my trainer tells me the same. He goes, okay, diet for one day. Look how you lose 10 pounds in one day. You're not losing 10 pounds in one day from dieting for one day. You're not going to gain 10 pounds from eating one day of pizza or one bad meal, right?
Correct.
I mean, wow. Okay, so we talked about dieting, any diet that's balanced and that you can stick to. Exercise. What is the best exercise? That's something that's changed. We were back to the Richard Simmons of the days of jazzercise. We had the belt that would make people thin. Then we went through all, through the CrossFit and marathon runners. Now it's high intensity interval training, Orange Theory. What is the best exercise?
The one you will do,
Oh.
just like the diet. It has to be something you'll stick to. You have to make time for it. You have to enjoy it. So I tell people walking is the easiest and least expensive. If you like to dance, find a partner and dance. If you like to swim or jog or run, play games, bike, whatever it is you enjoy. If you have to be in a gym with other people to do it. Accountability is very important with exercise. If you can find a buddy to do it with, that makes it more effective and you're more likely to stick with it.
Yeah, I agree with that. That accountability is a big deal because, when I don't get called, whether it be by my trainer or by a workout buddy, it becomes a problem. Now, let's break down exercise in regard to what I call, and please, rename them for me, aerobic and anaerobic exercise, or let's say cardiovascular exercise and, resistance training and muscle building. Should we be mixing those up as well? Should they be mixing them up?
We should. Everybody should be exercising about 30 minutes per day, an hour a day if you're trying to lose weight or keep it off. You want to do cardiac, you want to be getting your heart rate up to an intensity that's going to burn fat, and you want to be doing resistance at least 1 or 2 times per week. So you want to mix it up, and you can do little bouts. If you're someone that loses a lot of calories when you're working, like you're a farmer or someone doing heavy labor, they don't need to exercise the same way. They're obviously burning a lot of calories, but people who are sedentary, sitting at a desk all day long, they need to be moving around, getting up and going to the water fountain, getting up and going to the restroom, getting up and moving. That makes a big difference. And even having something under your desk, like a little bicycle or something, can help. Or walking before you get to work. There's all kinds of ways to be inefficient and burn more calories. So exercise doesn't have to be the normal, I'm going to the gym or spending 30 to 60 minutes exercising.
All right. So we've heard about lifestyle changes. Lifestyle changes is complex. I don't think I can, reiterate that as cleanly as you did. But obviously making lifestyle changes, eating correctly, planning for your meals. We've heard about eating correctly, correct eating habits, and let's say dieting and having the correct meal plan. We heard about a mixture of different type of exercises, exercising 5 days a week and a combination of resistance, weight training, as well as cardio. Okay, now let's get into somebody who needs medication. And, in the old days, there was not a lot of good medication. People went through the history of fen-phen, I guess. And maybe let's start off with fen-phen and what it was and how bad it was for people. And I heard about those stories about people having, pulmonary hypertension, high pressures in their lungs. So what is the history of medication for weight loss?
So medications have been around since about the 40s, and we started with a lot of stimulant type medications. Fen-phen is the pairing of 2 of those, and then you had the Black Beauties and all the Ambars with amphetamine in the 60s and whatnot, and those were taken off because those caused some problems as well. And phentermine has made it through all of it. It's a good, sound medication. Loses about 5 to 10% of your body weight. So it's good, but it's not real effective. And it has to be combined with diet and exercise and lifestyle. You can't use those and think it's a magic bullet. Nowadays, we have more choices. We have fat blockers and we have carb blockers, and we have this new class of medications which was used for diabetes initially called GLP-1 analogs, which actually go in and make you feel full. They actually slow the stomach emptying, and they really have revolutionized the pharmacology for weight management. It really is amazing to see that some of them have effects almost as successful as the surgery's having now.
No doubt. All right, so let's get back. So phentermine is still a good drug for weight loss?
Correct.
And it's safe?
It is, if it's used properly. I mean, you can't prescribe it for more than a month at a time. I follow my patients very closely. I check their blood pressure and their pulse and everything. So there's a lot of things out there that you can use ineffectively. But if you're doing them, all the medications are safe with close supervision.
Okay. And then before we get into all the GLP-1 agonists and so forth, let's talk about all the other medications that exist. So there are some fat blockers. There were some medications that were causing people to have diarrhea, malabsorption, and so forth.
Right.
What are some of those other medications? And then there's also this Contrave as well. Contrave. Tell us a little bit about what are those medications?
Yes, those are all different classes. The Contrave works on the brain. It actually releases opioids in a part of the brain that makes you feel satisfied. So you have bupropion, which releases opioids, and naltrexone, which keeps them from being taken up again. So your body feels rewarded and you don't need the food for reward. It's a good medication. I use that in combination with everything else too. I like all the choices we have nowadays. There's probably 6 or 7 different classes of medications we can use to help, in addition to eating differently and exercising and changing your life.
Yeah, I think that's what I've heard over and over again. And I think, that's one of the reasons I wanted to start the year off with someone like you, because we talk about cancer here, we talk about heart disease here, we talk about strokes, we talk about all that. when I bring all these professionals. But, you know, really the foundation and the real basis of that problem is that obesity, poor eating habits, poor lifestyle choices, and that leads to that. Before we get into these other medications, lifestyle, sleeping. Is it a lack of sleep also associated with obesity?
Absolutely. I
You have
talk
to
to my
get-
patients all the time. You need to have 6, 7, 8 hours. The more the better. But at 2 to 4 a.m., you're resetting your cortisol and your insulin levels. So it's really important to be asleep in the middle of the night. And that's why shift workers have a harder time to lose weight, because they're awake at that time and your body's circadian rhythm isn't working properly. So it's really important to get a good night's sleep.
Wow. Okay, so let's get into the money into this, which is all these other GLP-1 agonists, which everybody is it's gone crazy. There's a national shortage. We even at Baptist Health, there have been notices out that, you know, we should try to reserve it for the patients who have diabetes and so forth. So there's the Ozempic, there's the Wegovy, and then there's the Mounjaro. So explain to us, you know, what they are, the differences, similarities, and what they can do for obesity.
So this is the second generation of this class of medications. Victoza and Saxenda was the first ones. They were daily medications. You take an injection. It's subcutaneous, a tiny little needle. It doesn't hurt. These ones are weekly dosing, and they actually can show weight loss in combination with diet and exercise up to 15 or 20%. So what they do is they help the stomach to slowly empty. Your body has a valve at the bottom of the stomach. The GLP receptor is there, so these medications clamp that down so you feel full. The food stays in there. It's slowly digested. You don't want to eat. It sends messages to your brain so that your brain feels satisfied. It actually changes behavior. I see people saying, I don't crave the same things that I craved before since they're on the medication. And they work a long time. The studies have been on them, and they've been used for over 8 years. So they're very safe and they're very effective.
And so what's the difference between Ozempic, Wegovy, and Mounjaro?
Ozempic and Wegovy are the exact same medication. Ozempic is the one that's prescribed for diabetes, and Wegovy is the new counter sister brother, what you want to call it, that's out for weight management for people with a BMI over 27.
Okay.
And Mounjaro is the new guy on the block, and that one's for diabetes only at this point. It's still being tested for weight management, but it's not approved yet.
And it's not the same medication as Ozempic.
No,
it's not the same.
It's different. It actually is a GLP and a GIP. So it has like an extra little hook that does another receptor. And all the research is in on that. It looks very, very good. But most of the data is coming in on Ozempic. The semaglutide is the one that shows that not only does it prevent and treat diabetes, but it prevents heart disease. And that's the really big winner there. It is cardioprotective. And I know cardiologists so want people on it because it's protecting the heart. The GLP receptors are all over the body. So it's doing things we don't even know. We just see the weight loss and the blood sugar effect.
Wow. Okay. And then in regard to these medications, safety. I was at a wedding, and there was somebody who was supposed to be with me at the table. And I said, hey, where's John and Mary? And they said, no, John been on Ozempic, and he's in the hospital with pancreatitis. So are these medications safe? I know that even Tylenol, right?
That's right.
Even acetaminophen can cause liver problems. And ibuprofen can affect your kidneys and give you ulcers. So there's no 100% safe medication, but are they safe? You know, what are the worrisome? If somebody's listening and they're using it appropriately, their doctor's giving it to them, or they're getting them in the black market, you know, what things should they be looking out for?
You have to look at a risk-benefit equation. You need someone that knows what's going on with them. So if you have a history of medullary thyroid cancer or something called MEN, which is very rare thyroid cancers, they're not to be used in that circumstance. People that have GI problems, they need to be screened effectively. I have people that have had things. Usually if there's a history of pancreatitis in the family or in that patient, you would not use them. If there's somebody's had other chronic obstructive diseases with their GI tract, you have to be very careful with them. They have to be used very slowly and followed by a physician, someone that really knows what's going on with them. So they are very safe, but there are complications. If you drink too much water, there's complications. So you have to realize the risk and the benefit with anything that we take in.
All right. And then one of the other medications we didn't touch upon, maybe it falls in one of the categories, and I've seen you use it, and I see this in the hospital among physicians using this medication, and they're not obese. It's metformin.
I love that drug.
Really?
It's an insulin sensitizer. It has been around forever. It is dirt cheap, and it helps people to lose weight, have less cravings, and prevent diabetes. It's used in pre-diabetics, the American Diabetic Association.
I see thin people, like doctors who are on 1,000 milligrams twice a day of metformin, and they're not obese and they're not using it for obesity or diabetes. They just, they apparently there were some publications that it is beneficial. Is that true?
That's right.
It is?
It helps insulin sensitivity, so your body has less insulin running around and doing bad things. And there are some things that it's an anti-aging medication that actually can slow the aging process down. So a lot of people use it for preventive.
Anti-aging. So,
Correct.
but let me clarify. You have to take it. You don't put it on your face
it.
to prevent the wrinkles, right?
You take it. It's a drug.
All right. So we talked about the multifaceted format to lose weight, and we talked about the lifestyle changes and the eating correctly. I don't want to use the word diet. We talked about exercise, and we talked about medication. So surgery, you know, I'm the first one that tells people, if you can lose weight without surgery, you're better off. But, you know, are there patients that you see right off the bat that you say, listen, you're going to need surgery? You know, if somebody's listening to us out there, is it a waste of time to start with medication, or should they just go to surgery?
No, it's never a waste of time. You have to change your lifestyle. You have to do things different, even if you've had surgery. And I'm married to a surgeon, so I know you don't want to have surgery unless you absolutely need to have it. So diet and exercise, lifestyle change, and medications are always the first thing that you try for a long period. And then there's some people that just can't succeed with that. They have too much to lose, and we're only getting about 20% off. So if someone's 400 pounds and they lose 20% of the weight, that's only 80 pounds. That's not enough. So there are times when surgery is needed, but it is part of the whole package deal. You need the other things as well. And even after the surgery, you still need eating differently, exercising, sometimes taking medications, and the lifestyle changes.
Yeah, that's one thing and there's no doubt we are seeing this more and more in our bariatric surgical community, that the medications before surgery and after surgery are helpful, because surgery has a limitation. Surgery has a limitation on how much weight you could help a patient lose. So if I can get the patient's BMI lower, you know, from a BMI of 60 to maybe 50, they're going to have better outcomes. And then long term, we know that there's a chance of weight regain with bariatric surgery. So that definitely helps the patients as well. So definitely, I think, you know, to answer my own question, yes, I think if you need bariatric surgery, you still start off with an obesity medicine specialist. You start with somebody that can help you with the correct habits and eating correctly, and then obviously possibly medication and eventually to surgery as well. So what are the recommendations you give for our population out there? What are kind of some, you know, when you meet somebody at a cocktail party and they realize that you are an obesity specialist, you know, what are the kind of things you tell people that are pieces of advice that they can go home with and they can, you know, put in their back pocket and use throughout their life?
Right. The biggest thing is you want to eat variety of foods. You don't want to cut any food groups out, in moderation. So if anybody can do moderation and variety, that's never going to change. That's the most important thing when it comes to eating things. Foods in their most fresh and picked and locally grown, things that are the healthiest things, and you want to move. I tell everyone you want to move more. You're not moving enough. All of us are sedentary. It's just our lifestyle we have nowadays. Anything you can do, whether it's walking or being more efficient, leaving stuff in the other room, taking the stairs more often, parking farther away, those are the basis for everybody. So if you start doing those things, that's already going to make you more healthier. And then the next level is you write down what you're eating and find someone who's going to keep you accountable, whether it be a food app online where you keep a record of what you're doing, or a friend who's going to do it with you. That accountability goes a long way.
Yeah, definitely. No doubt about it. What about those watches that, you know, check your heart rate and so forth? Are those useful, and would that be, are those accurate in regard to calories burned? And people that are trying to do that cardiovascular exercise, is that something that you encourage?
Absolutely. They can help too, but I don't encourage people to spend lots of money on things. There's things you can do without spending any money. There are free food recording apps out there, and you can walk for free. All you need is a good pair of tennis shoes. And a friend or someone to keep you accountable are the best things. You want to do stuff that's sustainable. And if it's going to cost a lot of money every month, then people aren't going to be able to do it. So they are a tool that you can use, but not necessary.
All right, and before we close, let's just quickly touch upon the American Academy of Pediatrics has made some recommendations just a week ago that says that we should, I think starting at the age of 2, we should start really paying attention to obese kids, 2-year-olds, 3-year-olds, that the age of maybe 12, we should start medication on kids that are obese. And at the age of 13, we should consider surgery. So these are obviously strong recommendations. Why?
So these didn't happen overnight. I was on a committee 10 years ago when they were talking about these, and it finally got approved. And the reason it's so strong is because it's really a problem, and kids are getting bigger and bigger every year. And COVID has changed things where they're more sedentary, and there's really a national epidemic with this. It's important that you start with the same foundations, eating right and exercising, and the whole family has to be involved. I can't iterate it enough how important the whole family has to be involved with the health and well-being of the children. So when those things have been tried and completely used up, then you would consider the next step, which would be the medications and the surgeries. And that's for children who are obese that already have that diagnosis. I'm all about prevention. So the more that people can do to prevent getting to that point, the better it's going to be. However, it's nice to know that we now have different options for children who are already there that have not been able to be helped previously, and we can use these medications and surgery as an option to add to eating differently, exercising, and changing your lifestyle.
Yeah, I think no doubt that the lifestyle change of not going outside and playing sports anymore, the fact that everybody's on their phone, their tablet, and the video game era and the social media era has definitely hurt them. Now, in regard to, we understand, eating correctly, we've already reviewed, correct choices. We talked about exercise, maybe enrolling the kids in sports and things like that. What about medications? Are we using those same medications on kids?
Some of them, metformin's been approved down to the age of 10, and now the GLP-1s, the new ones, Wegovy and Ozempic, those have just been approved. So they are being approved, and this is just brand new. This is taking everybody surprise, and the pediatricians are learning differently what to do because we didn't have anything but behavior modification, diet, and exercise until just last week. So they are there, and they seem to be safe, but that's in the last efforts after everything else has been exhausted, and the family still has to be involved. Everybody has to be treated when there's a child that comes in.
Yeah, I think that's the key. You've said it so many times, family involvement. But I think if you're an adult, you have to have the family involved. A spouse, who's trying to eat correctly and exercise and has another spouse who's eating poorly and not exercising, it's just not going to go well. Either one's going to fail or the relationship's going to fail. So I think, the family unit is very, very important in having success. So I want to thank Dr. DeRosimo for coming.
Thank you so much.
Thank you. Thank you for educating our population and our viewers, teaching us about eating correctly, wellness, and obesity, understanding the safety of what is available out there for our community. And so once again, Dr. Anthony Gonzalez, trying to educate our community, trying to teach you about health topics and making you more aware. So as we've mentioned many times here today, take care of yourself and your family. Do it as a family unit. Have the correct the correct habits. Do it together as a family, and obviously eat healthy and take care of yourselves. Once again, Dr. Anthony Gonzalez from Miami Community Health signing off. Have a great